Good morning. Welcome to UK-Nepal Dialogue Monthly Webinar Series. My name is Krishna Adhikari. I am the convener of the event, and also I will be moderating today's event. This is the third UK-Nepal Dialogue. The team behind putting this event includes Mr. Lokendra Purush Dhakal, who is the Executive Director of Center for Nepal History UK, Mr. Naresh Kapangi Magar, who is co-convener of the event, Dr. Sangeeta Swecha, who is the media coordinator, and Dr. Susma Basnet, team member. We have a bigger team of associates, fellows, and advisors. Some of them also are present among us today. Last month, we ran a panel on ex-Gorkha grievances. Today, it will be a research-based talk on health system in Nepal. Our aim is to alternate research-based talks and panel discussion on issues of contemporary interest in alternative months. Before I introduce today's speaker, may I remind you a couple of our ground rules. Please write your proper name if you haven't, if you have come with a mobile phone's name or something, so that we can identify there's a real and trusted person. And also, please stay muted at all times. The format of this program is that if you have got questions or comments, please put them into the chat box and we will take it from there. At no time, please do not unmute by yourself. If that's necessary, we'll request you. The program will run with the 30 minutes of, or about 30 minutes of roughly, of presentation, followed by question and answer. So there will be plenty of time for question and comments. Today's talk is given by Professor Padam Simkhada, and the title of today's talk is Good morning, and the title of today's talk is just to avoid the echo. The title of today's talk is Nepal's health system fit for purpose? It's a very big question we're trying to tackle, especially reflections on transformations, maladies, and future needs. Let me briefly introduce Professor Padam Simkhada, who among Nepalese and people engaged in the field of public health know him so well. So actually he needs no introduction. With his over 3 decades of engagement in health system, particularly in Nepal, but also beyond Nepal, as a practitioner, researcher, and academic. Padam Simkhada is Professor of Global Health at the School of Human and Health Sciences, University of Huddersfield. He has over 250 peer-reviewed journal articles and book chapters. He supervised about 50 PhD students, past and ongoing, and many master's students. He has inspired a generation of Nepalese health professionals, especially researchers and academics in the UK. Some of his students have successfully gone into academia and become leaders themselves. Padam Simkhada started his career as a practitioner, working for Save the Children in Nepal and the Ministry of Health. So with that practice, he did his research, did his master's degree from University of Brunel and the PhD from University of Southampton. And the past 2.5 decades, he moved to many universities as an academic and researcher, starting from Aberdeen, then Sheffield and Liverpool John Moore University, and recently currently in Huddersfield. He currently also leads his university, from the health department in terms of international collaborations, students recruitments, and he's a very deep interest in how the higher education system functions as well. Without a lot more, information about him, we are very keen to hear. It is very hard, challenging talks to try to summarize this big question, but whatever time we have got, I hope we will be able to have a deep engagement and discussions. I mean, not everything needs to be covered in the presentation, but now I hand this forum over to Professor Padam Simkhada. I request all of you again, please stay muted, but also remain active so that, please begin forming your questions and comments and start typing them in the chat box. Thank you. Professor Simkhada, over to you.
So, thank you, Krishna. Can you hear me?
Yes, very well.
So thank you for the kind introduction. I don't think I don't deserve those sort of huge introductions. And thank you so much. Thank you for CNS UK giving me this opportunity to share this the reflection of the health system in Nepal. So what I have a plan today is just give me a second. Yeah, so in the next 30 minutes, so I will be talking about what are the changes or the transformation we have seen in Nepal health system, in Nepal in overall, and also what are the current challenges Nepal has. The lot of my talk and the presentation would be based on the Nepal Demographic Health Survey finding or the research, and also the Nepal Burden of Disease survey, which I will share later on. And then I will share some of the future needs. And there's so many needs. We can't cover this in 30 minutes, but a lot of my talk would be based on the recently completed project looking at the impact of federalization on health system in Nepal. I have seen that number of my colleagues from the team is in this call, and then I'm sure they will make an input if necessary. It's just for the healthy warning that there is so much data in my presentation. It's a more sort of data-driven and more on epidemiological focus, on those one. And I would also like to acknowledge my few colleagues. Some of my slide on today's presentation is taken from Dr. Sushil Baral, who is in Nepal, and also I had some chat with some people working long time in health field and share my idea and my view, and just to verify myself whether my understanding is the same line as the other people think. But there will be some disagreement with a lot of people on this one. So I just want to start on this one. As you know, Nepal has a lot of changes. Nepal recently became a federalist state, and also country is divided into the 7 provinces. And those provinces are quite different in terms of population dynamic, in terms of population growth, in terms of family size, and quite unique. And then the Madhesh and Bagmati is the largest province, have about 21% population each. And Karnali is the smallest province in terms of population, which is about 6% population. In terms of the overall health system, there's major changes on the health system. There's a federal government, has the federal government that manages the overall health system in the country under the Ministry of Health and Population. There are 7 provincial health government. Some of them called Ministry of Health, some of them called the Ministry of Social Development, and so on. And there are 753 local governments that include municipality, rural municipality, and metropolitan city. So all the health system is delivered through this mechanism in Nepal. And then let's look at current population. As I mentioned, the Nepal current population is about 30 million. And it is predicted that it will be around 35 million by the year 2050. But the current population growth is very much static, not much growth due to migration and decrease in fertility. So let's see what are the transformation, what the change we have seen in Nepal in the last, if you look this, in the last 60 years, the Nepalese people are living longer. 60 years ago, the average life expectancy of Nepalese people was 38 years. Now it's 71 years. Mortality, either maternal mortality or under 5 mortality, children mortality has gone down significantly. 60 years ago, there was around 325 deaths per 1,000 live birth, now gone to 33. Not only in those one, there's a significant increase in terms of the people are, or women are going to hospital for delivery, and then the health worker presence during the delivery increased significantly in the last 30 years. If you look in 1996, only 10% of the women was assisted by the health worker during delivery. Now that gone to 80%. So this is quite a remarkable change in Nepal. And then it is predicted that the population, the Nepalese life expectancy is go further again by the end of this century, by the 21. And then it is expected that the life expectancy of Nepalese people would be around 85, 86 years. So it's quite a significant growth. And as I mentioned, maternal mortality has decreased significantly over the last 30 years as well. Even now, there is a 1.7 women are dying every day due to the maternal cause. And then the current maternal mortality ratio is around 151 per 100,000 live birth. And then to achieve the sustainable development goal, it should down to the 70%. By looking the current prediction, it is possible on that to achieve those goals. And not only on the maternal, there is a significant improvement on infant mortality, below 1 mortality, under 5 mortality, and neonatal mortality. And so there is a quite good progress. If you look, there's under 5 mortality, there's a 118 per 1,000 live birth in 1996, that gone down to 33. That's a significant improvement on those one. And also the nutrition status, there's around 57 child were stunted. The 57% means nearly more than half child were stunted in 1996. That gone down to 25. So the nutrition status is also improving. And the obesity is not the problem among children in Nepal at the moment in compared to the other problem. And also the Nepal has changes quite a lot on the cause of death. So this is one of the major changes and shift we have seen in Nepal. Currently, around 70% of the people die due to the non-communicable disease. And around 21% people die due to the communicable disease, maternal, neonatal, and nutrition-related disease. And around 8% people die due to accident and injuries. And then there's a prediction is that if you look, there's the more men die due to injuries. Obviously, men are more likely to travel, more likely to take the risky behavior. And the more women die due to the communicable disease, maternal, neonatal, health-related. And then the death due to the non-communicable disease is equal in the both men and women. But if you look this the pattern how the shift height changes, if you look the 40 years ago, the major cause of death was the blue line is the infectious disease. Major cause was the infectious disease, communicable disease, maternal neonatal health. The yellow line is for non-communicable disease, and the gray line is for the injuries. So after the 2002, the cause of death due to non-communicable disease is higher than the infectious disease. And then the major shift, you can see this is a bit complicated picture here, but what the key message here is that 30 years ago in 1990, respiratory disease, TB, maternal neonatal health was the major cause of death in Nepal. That now become it's not a major factor. So that if you look in 1919, and the major cause of death is a cardiovascular disease, chronic respiratory disease, and so on. So the cause of death has changed. And then it's the same thing. In 2010, around 60% of the people died due to non-communicable disease. That increased nearly 10% in 10 years' time. So around 71% people, even more, die due to the non-communicable disease. And it is predicted that that will even further increase to 76% by 2030. And it will go even further by 2040. So nearly 4 out of 5 people die due to non-communicable disease in Nepal. This is quite important, the signal to produce the health worker, what type of health worker we need, what type of health program we need. And then so that this is a quite important aspect of the health system. And then let's look the Nepal where we are. I mean, so those are the good progress. So where we are in the global standing, and then if you compare the SAARC country with the Afghanistan, Bangladesh, Bhutan, India, Nepal, and then some of the indicator are Nepal is in the middle. Most of the indicator are in the middle range. For example, skill attendance is better than Pakistan and Afghanistan, but not as good as India or the Maldives or Sri Lanka. Same as life expectancy in the middle range and so on. And then what about the other international index? And there is a number of index, and then how the Nepal is spending. In Nepal, the 60, if you look the current health expenditure is a $65 per person per year that the Nepal is spent for the health. Out of those money, the people, if let's say that if you need 100 rupees for your treatment, 51 rupees should come from your pocket, out of pocket. So in Nepal, on average, 50% of the money come from the pocket, and then the public spending, about 33% come from the government, and then the other come from the other sources. So it's a significant portion of the money people need to spend for the treatment in Nepal. And then if you compare that one, those out-of-pocket payment is one of the highest. So it's less than Bangladesh or Afghanistan, but people spend a lot of money on treatment in Nepal. And then what about the other index where we are, Nepal, in terms of we improve well where we are? So there's several index. One of the index people see compare the one country to other in terms of health is the Global Health Security Index that evaluates the country's capacity to detect, prevent, and respond to any infectious disease. Out of 195, Nepal stands at 111th position. So it's a same level. I'm slightly two position up than Bangladesh, but the much lower than other country. The other index people use is the Universal Health Coverage Service Coverage Index that measures countries' access to essential health service with a score ranging from 0 to 100. And the higher score means better healthcare coverage. So if you look in Nepal, it's not great. It's improved quite a lot, but it's still, for example, India ranked on the 67th position with a score of 63. Sri Lanka score ranked in the 90th with a score of 56. Nepal is a 129th position out of 195 countries. So we are in the bottom line in that as well in terms of universal health coverage with that index. So the key message is the Nepal has a progress significantly, but there is a still gap. Nepal has made a notable progress in improving the health outcome. However, achieving the universal health coverage remains quite distant goal due to the persistent challenge. And also the Nepal, the cause of death and the health risks in Nepal is changing. So the country need to train the health worker who can handle these new challenges. So let's look at the challenges then. So these are some of the progress, good news. So what are the challenges we have? The one challenge is we don't have enough health workers. We don't have if you compare this one, like there's a 9 doctor per 10,000 population, whereas in UK there's a 30 doctor per 10,000 population. It just give you idea. And then in Nepal, that doctor is counted on national average. But if you look in Kathmandu, there is a 1 doctor per 150 people, which is higher than the WHO recommend. WHO recommend the 1 per 1,000. But if you look in the rural area in Nepal, there's a 1 in 150,000. You can see the difference. So one of the major challenge in Nepal is the unequal distribution of the health worker. Even on this health worker, there's a huge migration at the moment. If any Nepalese doctor want to go for further study or work, they need to get the good standing certificate from Nepal Medical Council. So if you look the number of doctors who are looking for or who got this good standing certificate, and then it's increased significantly. If you look in the 2020, around 1,100 doctors asked for that certificate. That gone up to the 2,582 doctor took this GSC, or good standing certificate from Nepal Medical Council. Means they are planning or they are preparing to leave the country and go abroad. And among those, USA is the major destination for Nepalese doctor are USA, around 32%, then UK, Australia, India, and quite significant number of Nepalese doctors who work in Maldives as well. And then the red line here is is a number of doctors who pass the bachelor's level in license exam. And so once they pass the medical qualification, they have to sit for the license exam. And then if you look at there's no data available for last year, but if you look in the 2022, the pass rate was around 65%, but the 2,386 doctors passed the exam, they are eligible to work. But if you look on the same year, 2,189 doctors are taking the certificate to go abroad. So there's huge now issues about a lot of these doctors go for the scholarship. And sometimes people ask, we train the doctor in Nepal, providing that scholarship. If you study the doctor with a scholarship, you need to work 2 years, and then after 2 years, you are eligible to go abroad. So, and there's a different debate about whether it's a personal choice and whether how to manage the medical education is one of the major issues at the moment. And there are several studies looking at the why doctor left the country. I just pick up the doctor as an example. There's a similar issues on nurse and other things. So the study recently published, last September published, shows that around 63% of Nepalese doctors have feel some level of violence at the workplace. And they are professionally burnt out. Around 50% of the doctors say that they work long hours, and the issues about and around 84% of the doctors are not happy what they are currently doing in Nepal. So they reported that they are not happy, and there's a limited resource infrastructure in the hospital. They can't use their knowledge and skill, even they got that skill. And a lot of doctors has a frustration with the political instability. And also the other challenge are there's a limited opportunity for postgraduate study and also employment. So because of these reasons, there's a high rate of migration. And then recently, the International Organization for Migration published the mapping of Nepalese diaspora. It's quite important, interesting report. I would recommend you to have a quick look, people working with the diaspora. There's a barcode as well. And then that they did a survey around 28 countries around the world among Nepalese people. And that report recommended or the estimate that around 11% of the Nepalese diaspora working in the high income country are from the human health and social work related job, means mainly the health worker and the doctor, nurses, and other health worker. So which is quite significant number. So there's more doctor and nurses trained in Nepal currently working outside the Nepal. And that's another story debate. We can discuss this one. The other issues about the challenge in Nepal is the health insurance. Nepal government started health insurance officially in 2015. That's it started in one district. Now by the 2022, all 77 districts has health insurance the policy, and in the current up to the last year, around 7.2 million Nepalese are enrolled in health insurance, which is about 1/4 of the total population. About 25% of the Nepalese are now in the insurance. And then if you have a health insurance, you pay about the 3,500 depending on the family size premium, and you'll get up to 1,100,000 rupees treatment per year. And then around 2.2 million households are enrolled. And the last year, similar, there's a 7.5 million people make a claim. The challenge for the health insurance is that the cost for these, the health insurance last year was about 15 billion Nepalese rupees. But the revenue it generates from the insurance, from the people contribution, is about 3.5 arab. And then the government give around 7 arab from the government. But the actual, there's a big, the black hole. And then current system is not financially sustainable. So the demand, they have to pay back to the 15 crore, and it's just a 10, 11 crore the income. So even the government put the significant money on that part. So the many people believe that it's about to collapse. And then also that there is a lot of issues about politicalization of Nepal Insurance Board. And then there's a link here, and there was our health minister gave the talk about the challenges of health insurance in Nepal and how to tackle that. And then because of the limited time, I don't play this his short video, but he highlighted that there is a misuse of resource in the insurance system. Sometimes there is unnecessary checkup, sometimes unnecessary claim, sometimes that's why. And then the health insurance system in Nepal is I think it's a best option, but it's not working well. That need to be fixed up. And the other challenge is that the disparity in the geographical distribution and development. So one of the index that people see how the society countries develop is called Human Development Index. That will measure on the basis of life expectancy, literacy rate, knowledge level, and the quality of life, or the GDP, or the GNI index, so which is the decent standard of living. If you look this one, and there's the 7 provinces I mentioned Nepal has, the SDI index for Bagmati is a 66 compared to 5.1 in Madhes. There's huge difference in terms of human development in these countries. Not only the disparity in the SDI, there's huge disparity in the fertility rate, and you can see that the fertility rate has declined. But in Nepal, the people with no education has 3.3 fertility rate compared to 1.6 with the people with higher education. Same as in there is the different fertility rate with the different ethnic group, and also the different the wealth quintile. The richest people now stop having a children. So the richest people have just 1.6 child per family compared to 2.8 for the lowest group. This is it's a quite big changing. So if you look at the better health outcome, you can guess which province has a better health outcome. I'm sure in the audience there's a lot of people from Gandaki province, and then Gandaki province has a better health indicator, like the neonatal mortality rate, infant mortality rate, under 5 mortality rate is the best it's the lowest in Gandaki province. And then the health facility delivery is the lowest in Madhes. Even there is that's a big question. Initially we thought that you need to provide the service. If there is a service, people go and use it. That's no more any truth. Because in Tarai, in Madhes, there's so many birthing centers, so many health facilities. But if you look the skill attendance at the delivery, it's quite low. There are a lot of other factors that contribute that one. So it's not just the setting of the health facility. We need to do a lot of other social change aspect. That's also the important. And also the Gandaki province also has the lowest rate of malnutrition in compared to the other. And there are some other indicator which is better in Bagmati, but in a lot of health indicator is better in Gandaki. So and also the number of the other, if you look the other indicator, there's huge inequality in terms of the distribution of the teaching hospital or the medical school. So if you look, Bagmati has a 13 teaching hospital, whereas Sudur Pasim has none. So there is process. Karnali has 1. And same as general hospital distribution. There are 79 general hospital, which is 100 to 300 bedded hospital. And then the Bagmati has 26 out of 79, whereas Karnali has 3 and Sudur Pasim has 2. Same as other distribution of the specialized hospital. the super specialized hospital and also the health facilities is not equally distributed. My point here is that the and also the place of delivery between rich and poor. And then if you are rich, 98% of the rich people give the birth in presence of health worker, in compared to just 65 if you are poor. Means there's huge inequality between rich and poor in terms of service utilization and use of health facilities. So the point, and same as in there's a huge difference between rich and poor. So the neonatal mortality among the poor family is 26 compared to the 13, nearly half. So what it means is if the child born in poor family, they are 2 times more likely to die in the neonatal period. Same as you can see the difference on under 5 mortality is in the rich family, is the richest family is a 16, and then the poorest family is a 53. It's a 4 times. So under 5 mortality rate is the if you are poor family, you are 3 times more likely to die during under 5 age. This is the challenge. So we are talking about the challenge. And other challenge is a loss of professionalism and ethics. I put this a real story about Sunmaya. I don't know whether you have seen that Sunmaya was the pregnant woman have a problem, and from Dhading she was coming to Kathmandu. When she arrived in Maleku, driver started to negotiate with the different private hospital, and then whoever hospital give the more commission, and the driver was trying to take her on that hospital. She preferred to go to the Yaks hospital, one hospital, and driver say that, oh, this hospital today they are closed, or there's no good doctor, so I will take you better hospital. And she was indeed with the very the another hospital. And there's a news about the chief minister in Madhya Pradesh last week acted as a driver and tested whether what sort of the response they will get from the hospital. And every hospital was trying to asking him to bring the patient on his hospital. So the point here is that there's so much commission and then unethical practice going on due to the several reasons. And there is issues around the challenge about the medical education and health science education system overall. And also that there is issues about hierarchy and among the healthcare worker, and then the communication gap. There are several other issues here. So the key message here, what I want to highlight here is there's insufficient investment in health. We have seen that people pay quite a lot of money for the healthcare treatment. There's a widening disparity. There's the huge inequality between poor and rich, educated and non-educated, rural and urban areas. And then to some extent, there's a worry that whether we are losing, Nepalese society are losing the ethics and professionalism in the healthcare sector. So the commercialization and privatization of healthcare have raised the concern about professionalism and ethics leading to the poor practices. And that's something is a bigger, wider societal issues that need to address. So my third part is because of the time I need to run. And so what's the future need? It's a very difficult question. Probably there's no one solution. So I just want to highlight that there's the impact of fertilization project. This is the number of colleagues from UK and Nepal. We did the one longitudinal study looking at how Nepal's move to the federal government system impacting upon the health system at all level, federal level, provincial level, and local level. It was funded from Medical Research Council UK, and we have 3 Nepalese university, 4 UK university involved, and many of my colleagues today are in this talk. And we did it's a multi-year longitudinal study using a mixed method. I don't want to go detail about this one. And we did the study in Karnali, Lumbini, and Bagmati. And then overall, what we found is that there's a lot of debate about whether the federalization is working or not on the health system. So our aim is not to look whether federalization is good or bad. Our aim was to see what impact it make on the health system. And there are some positive and there are some negative or some challenges. Some of the positive things are overall there's an increased resource available on health system because money go direct to the local government. There's a lot of new building going on. There's a lot of construction work going on, and also the improved availability of essential medicine. And importantly, a lot of health workers are now present on the health facilities because they are under the local government. If people go for training or go somewhere else, they will follow it up, and then they get some training. Overall, there is a positive. And then even in the COVID time, I think local government did really good job, and it's a seen as a good practice in that way. So there's a lot of good things going on, and then when we look the what Nepal need to do when we talk about the health system, there's a you need to address the wide range of issues. So it's called building blocks. So we need to issues, and then our study also focus on this 6 building block, and then for the future as well. If we really want to the health system in Nepal, that need to focus on leadership and governance, finance, human resource, information system, and service delivery and access to essential medicine. These 6 are the key core component to give the best health to the country. So, and then our study also looked in each component, what's going on these component. And there's I saw that Dr. Sarada is on the call, and he led this paper along with other colleagues. And we looked at overall overcoming the challenge facing in Nepal health system during the federalization. And we analyzed all those building blocks. And if you are interested, you can read this paper. It's freely available. And overall, there's a lot of positive things, but also there's a lot of challenges. So in the leadership and government, for example, there's a concern about the clarity about division of labor between the provincial government and local government, whose job is this one. And there's a clear, the lines of communication between government level is not always functional, it's not clear. And in many places, what we found is health is not a priority, is making a new building a view tower and building the other things is the priority rather than the health. Same as health financing, there's not enough money and to address the problem. Local government are not always allocating enough resource, and this is the major challenge that we face. The lot of health workers are not happy at the moment. They are not keen to work under the political leader, and also there is a mismatch due to the readjustment. Some senior doctors are working with under the junior health worker, and that's create the problem. And there's several issues about the limitation of health workforce, and also that there is the limitation of health workforce data to undermine the ability to make the evidence-based decision health workforce, what type of staff shortage is needed. And same as the medical product, vaccines, and technology, there's some challenge in terms of procurement. All the authority is given to the local level, and sometimes nobody put the tender. If they need a few thousand paracetamol, none of the company will go and put the tender, even they can buy. So a lot of things they're given in the local level, but local level is not ready to absorb that one, to do that task. So there's some challenge. And health information system, this is one of the weakest part. I think Nepal government recently in the line with the digitalizing the health information system, but the limitation in the data quality, data management, and also there is a very limited the data to make the evidence-based policy. And separate health system management, information system, data system, and the data system is not communicating each other, and that's why it's a quite big challenge for health insurance and the personalized treatment. And then the one hospital, even not all the private hospital data is available. So there are several challenges on these areas. And service delivery there is a establishment of birthing center, for example, is not strategic. It's a more sort of one group, one municipality put the birthing center in one area, and next to the river is another municipality. They put the birthing center there. A lot of birthing center now is poorly underutilized. It's similar to the school, and there's so many schools started. There is hardly any kids on the school. There's 3 or 4 kids in the school, and the half of the birthing center in Nepal don't give the enough birth to sustain. You know, I mean, there's a 3 or 4 health worker, but there are hardly 1 or 2 births per year. So is the worthwhile to have those ones? So the service delivery issues is a one of the major issues, and the political rather than the health concern influence the decision in terms of service delivery, where to put the service, new health facilities, and then there's a risk of lower quality of health service provision due to the reduced technical supervision, review, and the training of the local workforce. The one of the things when I talk to the people in Nepal, the health workforce and mobilizing the health workforce is the number one. It should be a number one priority if we really want to improve the health system. So and from our studies, we make up some detailed recommendation. We hand over that, we gave that recommendation to the Nepal government, and then there is the impact of fertilizer Nepal Health final project recommendation. You can get it; it's available in our project website. And then our recommendation were building the capacity of the health system planning and management at local level, improving the management, development, and distribution, and retention of human resource for health at all levels, enhancing the cooperation and communication between different levels of government, and collecting, sharing, and utilizing the high quality data to inform the decision making, and making and implementing the new legislation, regulation, and policy that required to address the problem. These are the key recommendations our team made to improve the overall health system in Nepal. So finally, this is my final slide, is the Nepal has improved a lot in the last 30 years, but it's still a long way to go to meet the universal health coverage. Non-communicable disease are the major disease burden, but the prevention program for non-communicable disease is still in infancy. And then health worker, what we've, I mean, so in my experience and from the other project, what we have seen is that the health worker are not competent, or in other words, they are not used to with the dealing with the many non-communicable disease, and mental health is an emerging problem. A comprehensive transformation of the health system is essential, with the strong emphasis on developing and retaining the human resource for health should be a key priority. Combining the national health insurance with a strong public health care service, and also involvement in the private sector is crucial. The role is quite significant, and Nepal needs additional effort to strengthen the public health surveillance, cause of death registration, and evidence-informed policy making. So our surveillance system is not good. That's why, I mean, if you look at the global the health security index, we are quite below. We are quite in the bottom. It's a number of this region. Yeah, with that one, I think thank you for listening. I think, Krishna, I took slightly longer than you have given me, and I'm happy to take any question. So probably I will stop sharing the slide.
Right. Thank you, Professor Simkhada. We have got slightly less than half an hour to engage in question and answers and discussions. And, you know, I was thinking about this is a great presentation. Actually, you managed to cover you know, a lot of information on Nepal health systems in nutshell, in short time. I was thinking about the picture you presented, you know, a picture of optimism, of course, with challenges. I think this is quite resonated with the David Gellner's question here. Of course, you know, even though some of the colleagues have also, you know, given some ideas about on this question, maybe it would be nice to engage with you that the improvement in health indicators in the last 50 years are truly impressive. How much of this is due to Nepal government action, and how much is due simply to rising level of education or anything else? What's your take on it?
So thank you, Salai. That's a very good question. I think there's a number of things. If you, I mean, so when I graduate, I work as a health worker in Sindhupalchok and working on there. And then I'm just recalling at that time, I think that the role of Nepal, the female community health volunteer at the community level has a quite significant role improving, particularly indicator related to maternal and child health, because they are the first hand health worker available in local level. I think Nepal invested on those, the female community health volunteer is a quite significant. But of course, when we look the health indicator outcome, it's a clear that there's a number of wider factor is a very important. It's a education plays a crucial role. That's why if you look the globally, the educated people are more likely to use the health service. So those has an economic condition improve and reduce in the poverty level has a quite significant contribution. And also, I think in Nepal, we shouldn't forget that the role of civil society is quite significant. And then when I was in Sindhupalchok at that time, the Save the Children was the major healthcare provider in the whole district, and that has a quite significant improvement. Even the if you look the investment, government investment on health is not high. If you look at Nigeria and compare that, I didn't have time. I put a few slides here. I didn't share. That I looked the Nepal and similar countries, and the other countries invest more on health, but they have a poor health outcome in compared to Nepal. Nepal has invested a small amount of money, $65 for the per person per year is a quite low range, and the achieve that Nepal make is quite significant, quite impressive. But there are other factors that has contributed on the improvement in the health outcome in Nepal, like the level of the people's changes in understanding. One of my PhD student, Manju, is looking at the skill attendance at delivery, and she compared the Bajura and Mahottari. Bajura is quite remote, and the Mahottari is quite center. But the utilization rate and the health indicator is much better in Bajura than in Mahottari. And what we found is there is a women's level or women's autonomy was the major determinant for utilizing the health service and family support. Whereas in Tarai, women didn't get that. In Bajura, they got it. So it's not just having a health facility. It's not just having a, so there are wider, bigger factors that determine the outcome of a health indicator. So coming back on that question, I think number of education, poverty, women's empowerment, and then the wider determinant of the health is quite important to improve this one. I think Nepal did well in some extent on those areas. You're muted, Krishna.
Thank you. For now, I think since we have some time, I will take questions in the order. Here,
Please.
Prabhat is asking that the brain drain, especially the migration of doctors, he's trying to understand whether the rate, the pace of migration, does that follow other Asian countries, for example, like India? The rate of migration of Nepalese doctors and professionals, is that in line with the other Asian countries?
That's a good question. I mean, I don't have a data in front of me here. I can provide that if you email me. There's a health worker migration is common. It's happening everywhere. So there's a lot of British doctors go to Australia, New Zealand, other country. So migration is a big problem in the UK as well. The number of doctors trained in the UK don't stay here; they go to other country. But the rate of migration is quite high in Nepal. So the number of people in the last 4-5 years, the number of doctors who left the country is a significantly higher than, definitely higher than India. I looked at is highest in the SAARC country. But it is a lot of Indian doctors go, and the production of doctor is that's in India is a quite significant. It's a massive country. It's huge, but the definitely there's a high migration from Nepal to other country at the moment. But there is a migration everywhere, the health worker migration everywhere.
Right, great. Here we have Lakshmi Panta. raising question about the professionals' mistreatment in Nepal. Is this linked to the privatization and commercialization of the health and education sectors in Nepal? I think these two aspects of neoliberal, changes, a private sector providing health and education, significant chunk of it in Nepal is a big question. Maybe that needs due attention. What's your take? Not only in terms of protection of the workers, but these, we are talking about the health systems in Nepal. Is that the model to pursue? And is this, working? Or, it's a big question anyway. But what's your, simple thought on it?
Yeah, no, I think that's a very good question. Thank you, Lakshmi. I think there's a number of things we need to consider when we talk about these issues. So Nepal, there's a privatization happened after the democracy in 1990, and there's a good thing is that a lot of medical school and health science colleges is started both in government and private sector. I think that was a good step. Otherwise, Nepal wouldn't make this progress in terms of the health worker capacity, even supply the doctor and nurses for the other country. But at the same time, the way it managed, I think, in my view, that there is some weakness happen, some mistake happen, and that's why there is we lost some of those the medical ethics and value, and that created those the some of the example that I gave and you raised earlier. At the moment, the government is not absolutely clear whether we encourage the privatization and in terms of the medical school, nursing school, or whether we should discourage that. So I will give you an example of the challenges that from the private college provider, private education provider view, they also facing a lot of challenge. When I met with them, discussed with them, and they always have a several comment and complaint that, for example, quota system, the medical commission give the quota for each medical school, either government or public, and that quota system change every year. I'm public health graduate, so in public health, sometimes the one college get the 10 places for 1 year, and then another year they get the 5, another year they get the 20. And how they can manage the academics and other academic planning? So and then it's a most, this, you got the college, you got the 2 places for MSc nursing, 5 places for the master's in public health, 2 places for MD, and those sort of the small distribution approach that the currently going on, I don't think that's working. So rather than on that approach, it should be, okay, you specialize in nursing training, you specialize in pediatric nursing, you specialize in public health, you specialize on radiography or whatever. Then if we move on that direction, it will be benefit both for government and private sector. And then the other thing is the health medical thing is not same as the privatization of the telephone company or the other goods or product. People don't know that. I mean, if you ask you to do that the blood test for and it costs 1,000 rupees, and you won't have a time to go and check in the other hospital whether the same blood test is done in 500 rupees or it cost more, because there is no market comparison in the healthcare sector. If you are emergency in a hospital, you have to do it because you will do it because there is a life and a death issue. So and the country like Nepal and having this sort of the putting the business on medical education is a real challenge. I think that creates some challenge in terms of the ethics and professionalism on the people. There's a both side. I think there's just so many cases of medical negligencies and then the malpractice. Recently, there's a one private hospital. They did the blood. I mean, all the lab were fake. They just make it the data, so there's no actually lab test, and they find out that there's such a malpractice. At the same time, and then there is not enough facility available in the public government sector, and people have to go to that private sector, and then there is a perceived quality in the private sector. Okay, there's a good, you will get a good service in private, and that has some confusion for the people. So one, I think, yeah, I agree that the ethics and professionalism is a questionable, and that need to fix. It's not just the medical field or health field. It's a more sort of wider society and all the marketization of the whole issues. And also at the same time, the way that we have managed the private hospital medical school, that need to the revisit. That's my point. So the current the model is creating this problem because they need to have a financial viable, and then the use the but the to be a financial viable doesn't mean that you have to do the wrong practice. But at the same time, there's a lot of there's in Nepal medical education. There is a different debate about the Govinda cases movement on the medical education. That's a completely another area. And then some people agree that that was essential. Some people say that no, that destroyed the whole medical education and medical system in Nepal because of the unnecessary unnecessary control and the control of the freedom of the medical education. So some of the country which is doing really well. I mean, so we can see that there's even providing the private sector on the education side is doing well. A lot of country has that they produce the doctor in the private sector, but they work in the public sector later on. But the basic rule is that those country who has a better social security and government health system is doing well. I mean, so I can give you the example from Cuba and US. There's no any political reason, but if you look in America, they spend about $14,000 per year per person. $14,000. Cuba spend about $1,100 per person per year. If you look the basic health indicator, maternal mortality, life expectancy, infant mortality is better in Cuba. The reason is that they got there's been so much focus on primary health care, and so much it's all the services provided through the government system. And then if you provide the better management, it could and that's more health worker available in the market. But the other flip side is that they don't have a sophisticated, high-tech, ultra-modern service. And then if you need those service, tiny percent, 0.1% of the people need that service, but those services available in US. So there is some positive aspect as well on the US healthcare system. Sorry, I think in the summary, yes, it's a time to think about how do we correct those the losing the professionalism and ethics in a Nepal health system. That's a quite challenging and quite touching issues. And I think the way it's managed the private sector, I think need to revisit. That's my observation.
Right. I mean, this is itself a very big question anyway, which
Yeah.
requires another presentation. And we have got a range of questions here. I don't think we will be able to cover all of them, but I think we can extend, because our original plan is to complete this by 11:15, but we can extend by another 10 minutes or so if necessary, and people who have got time can remain and get engaged. There are questions about sustaining the systems. The health insurance, for example, how effective it is in the in practice, was a question itself addressed by the minister that is running through crisis and resources. There are questions about NGO and INGOs providing resources, but the global order in some sense changing, funding being stopped, the USAID programs been cancelled, UK government reducing its international funding, so on. I mean, I'm just giving the example of the global trend here. So there are questions about the NGO and INGO, doing services in terms of raising awareness and providing public health services. But also question there is by Bhagirath Yogi about what can we do to sustain this health insurance? Is this helping the working class people in Nepal? Is it important? Should government worry about making more investment, about 6 Arab or something? Is that huge money in terms of public, securing public health? I mean, this is a big question. Maybe, some thought on it would be, warranted.
Yeah, so thank you, Bhagirath sir. I think this is I remember that 10, 11 years ago when you were in BBC and you interviewed me about when the health insurance was just started. I remember that time. Now, and then one of the things I mentioned at that time, if I remember correctly, was that the Nepal infrastructure was not ready to cope with the health insurance. Health insurance system need a well sophisticated and well coordinated approach. And then there is a different model of health insurance system around the world. And there's the American model is a different, and the Japanese model is different, Korean model is different. I think the model that Nepal adopted at the moment is again the link with the professionalism. The one of the challenge for Nepal at the moment is the premium for the insurance is low, but for Nepali context, for the majority of the Nepali, that's quite high. So they cannot afford the high premium. And the government put the nearly double the money on this health insurance pot. And then, as I mentioned, so the government give about 7 to 8 arab per year, and then about 4 arab from the people's revenue. But the total expenses in a year, the last year was even 17 Arab. So there's a real big hole. So I think that there's three things that I think need to change. One is the current model, how that operate. It's not only the health insurance, there is other additional. If the people have for example, chronic serious disease, there's a definition of serious disease like cancer, they get another 3 lakhs from the central government. And some province also put the additional money, 2 lakhs, 1 lakh for those people who have those sort of the kidney problem or cancer or so those. But those premium, those support doesn't talk each other. People don't know who is getting from which source. System doesn't know those things. So in one level, the whole the data information system and then the health insurance system need to manage well. The first thing. Second is, and there's a lot of the mispractices. So we need a lot of education both for public and provider as well. So the lot of people are why there's a low uptake, because a lot of people don't trust on the current provider. So if you look at just 25% people are enrolled on the health insurance. So the enrollment in the health insurance is quite low. Even those insurance people who enroll, dropout rate is quite high. So they don't renew next year. And then the main reason for those dropout is they are not happy with the service they got. And the service is not they are thinking. The people who use the service, and also there is a misconception that I can use 1 lakh for 1 year. So even sometimes it might be necessary, but they go there, and there's a quite interesting story that minister also share that they spend 90,000. Oh, I still have 10,000. I will go and do another blood test or urine test, whether I got any problem or not. So there's a real misuse. And also the nowadays, again, the professionalism issues is very important in Nepal. That's why I keep saying is that there is people go to the private hospital, they just make the bill and claim for that bill. And then those are issues. There are several such incident is reported that is not actual the expenses, or they make it, just they make it. And also so basically, and so probably Nepal need a more mixer system in the some contribution from the people, even for the treatment share of the cost. Definitely the money that we put is a peanuts in terms of the in Nepal. You can see that the $65 per year per person is in terms of global norms. It's not a lot of money, and they
Yeah,
definitely
can
yeah
I just interrupt to relate
yeah
the questions here, which I also highlighted? I think Naresh Kapangi, I just raised about recent development of the USAID UK government's
yeah
international development assistance being massively slashed. Also, your point about the misuse of resources. There's a question by Sarda Manandar, uh, Shraddha Manandar, I think, is that right?
mm,
About disproportionate rise in rate of cesarean deliveries in Kathmandu.
Yeah.
Is that due to the incentive of the abuse of the resources to make the financial gains? All those kind of points are here. Uh, Related to that, I think Bhakta Gurung also has asked about is there seriously lacking some kind of control and regulation? He gives one example from the Madhya province, but from the governments. I don't different things there, but about the resources and controls and the abuse of funds, all related to somehow the health governance. I mean, if you want to add anything, but I think thanks to Edwin and Resam Khatri, they have also given some good links out there in the chat box. What you would like to say about the global trends, our resources, our
Yeah,
own
thank you. Thank you, Krishna. I mean, so there's a lot of interesting question and it takes a long time. I think thank you, Edwin. And Edwin has done a lot of study and one of her PhD student just finished the PhD on looking at the cesarean section and the overuse of cesarean section in for example, in Chiton is one of the classic example that people say that all the women in Chiton will lose the uterus because there is so much operation going on, and there are several sort of rumor before the coming to that one and the Naresh, I think your question, the role of international development in developing countries is quite significant. The current announcement from the US government, I'm sure has some impact on Nepal health system because if it was 30 years ago, it was chaotic. If you look at the data until 2010, the proportion of the health budget coming from the bilateral donor and then the foreign aid was significant. At some point, 70% of the Nepal health budget was based on the foreign donation. But luckily, and in the recent time, those proportion is quite small. So the health budget is not dependent on the foreign donation. It's quite small proportion of the budget is only coming from the foreign donor and the bilateral organization. So, but there are certain programs which is directly supported by USAID support, like a nutrition program, maternal health program, and vaccine program. So, like the Nepal recently started the vaccine for the some of the cancer and they started the vaccination to it's coming those vaccine was supported from Gavi, which is a global alliance for the vaccine, and then the USAID has a significant proportion of support on those Gavi programs. So after cutting those funding, some of the program will definitely affect it, but I don't think it is a catastrophic or it is a disaster in Nepal health system, even without the foreign aid at the moment. That's the one thing, of course, in Nepal, there's a sanitation program, WAS program, and the nutrition program is a major program that USAID support, and that has, I'm sure, contributed quite a lot on reducing the malnutrition in children. And the Shraddha's question about cesarean, I think Edwin has shared the link on the paper. That paper has a quite good explanation. There's a unnecessary increase of cesarean section in Nepal, and that's again driven by the commercial benefit, the financial benefit, rather than medical need. That's my takeaway. Krishna,
Okay.
any other question I missed?
Yes, there was a point raised by USA about the access to drugs and I think use of microbial antibiotics. I guess if I can take the question somewhere. But I think more or less that has been covered. Yeah, the great presentation. Okay, accessible are essential medications for the population in Nepal. Additionally, antimicrobial stewardship is of worldwide concern and has significant impact on the treatment options. To what extent is this a concern in Nepal? What intervention are being taken? And maybe you can, just give an answer in one liner or so, because I want to now enter to a other bigger question. If you answer first.
That's very technically. Microbial resistance is a problem in Nepal. I think I don't know whether I couldn't actually pick up the question. Probably I can This is in our analysis of this one, DHS. I'm just looking the question. Sorry.
Question by Usa Adhikari. That was about the antimicrobial stewardship. To what extent is this a concern in Nepal, actually? The use of antibiotics.
This is it is a problem. I mean, so we haven't gone to the individual health problem, but it is a issues and because there's in Nepal, you can buy the antibiotics in the counter, and then and also there's a overdose, misuse, incomplete use of antibiotic is a quite common. So there's a lot of issues related to those one.
Right. Okay. I mean, since we have got a few questions and there's a good number of participants here, we are extending this program by 10 minutes. We have a question here by Ranjita Dital. This says, what are your thoughts on reducing NCD? So I think the non-communicable diseases in Nepal, which is growing into a major problem or ticking time bomb, especially training and engaging health and social care workforce. Should we extend the scope of healthcare workers to include other types of workers, i.e. develop a more community approach, interdisciplinary public health, optimize? So I would like to have your thought on this one. This obviously will link up to our question about how to stop the migration of the health workers. It would be a bigger question anyway.
Randita, I think that's excellent question and most difficult question. I think, definitely. If you look at global evidence, so having, I'm not against the establishing the big hospital. Don't take me other way around. But the medicalization and the healthcare and the medicalization of the whole profession, just focus on medics, does not help to reduce the non-communicable disease. So if you look in US, that US spent the largest proportion of the money per person per year, and the US had the highest number, another highest number of non-communicable disease. So if you look the non-communicable disease risk factor, there's 4 key risk factor: lifestyle, the eating habit, your drinking habit, and then and also your walking, and also the smoking, and the pollution exposure. So if we really tackle the non-communicable disease, it need to be a multi-sectorial approach. It need to address. So in Kathmandu, if you don't have the nice walking footpath, and then you don't walk, you take the car or you go with the vehicle, and that has impact on non-communicable disease. So the planning division has a quite important role on reducing the non-communicable disease. And then if you don't have a proper exercise places or the working place, working culture, either school, college, everywhere. So every sector need to involve to reduce the non-communicable disease, because the only way of the at the moment the priority is not in the prevention. So for me is that they need a very good preventive measure to reduce the non-communicable disease. That's the only way you can reduce. And the treatment is there. Of course, you need a treatment, but the prevention should focus on non-communicable disease. And then if you look, I haven't shared that slide, but if you look the money that people spend on the insurance money or any other money that people spend nowadays, 60% of the health expenses goes to treat or the care of non-communicable disease. And that will stay forever. And then when the people are older people with the multiple non-communicable disease, the treatment cost, all the health costs go up. So it need, and basically we need a multidisciplinary approach, multi-sectorial approach. It's not the work of Ministry of Health or Population. It should be the work for the education. It should be work for the nutrition department, agriculture department, the urban planning department, everywhere, and changing the culture of the food habit, and that why the obesity is quite low in Japan and quite low in some Asian country, Vietnam. It's a culture as well. It's a food habit and other things. So that it's a bigger problem, and it need to tackle with the multiple approach.
Right, thank you. We had a question from Sunil Paudel. I think we talked about the protection of his staff and holding the people having high potential within the country is a big question. Then your research and presentation showed that we already have a limited doctors and nurses, especially outside Kathmandu.
Mhm.
It's a huge international migration problem. Developed country, needing more and more health professionals, and developing country making huge investment and essentially eventually sending the trained manpower to the developed country. Uh, has there been any example anywhere that could be followed about the, reverse migration, or, any measure the countries could take? This is
Mhm.
this is going to be a huge challenge, actually, especially,
Yeah.
especially as we are funding, the developing countries are funding for manpowers who would eventually serve to the,
Yeah.
developed countries.
Yeah, that's very good question. And again, in the difficult question, there are some example of reverse migration in other field. I have seen that. I mean, so you can look in the South India. There's a lady from Silicon Valley moved with the IT team, and 500,000 Indian move returned to the South India and set up the IT company and all the business. So there's so many Indians, American Indian, return to India and have a good quality life, and also done a lot of good things. So there are other example in other part of the world and other area, but in health sector, this is the big challenge. And you are absolutely right that the producing one doctor in UK costs so much money, and then the UK is getting the almost free trained doctor over here. The doctor is highly qualified, widely trained, and they are here. And uh, so so that's why I mentioned earlier that I think our education system, how we train the doctor and nurses, health worker, need to revisit. For me, is a um, uh, there is a mandatory 2 year work provision, and then whether that's enough, long enough. And also, we cannot stop the people from moving. It's their personal right. We should allow them to move where they want, but there should be a mechanism so that people choose to stay in the home country. So that's again is a bigger socio-political question and socio-political development issues. If the people have a better life, decent life, and then they will stay there. I mean, so we have seen that the doctor in Nepal who are doing the residency, they work 12 hours a day, and they are not getting a 48,000 per month as a part of their job. And there is a big debate, and Prime Minister was involved to resolve these issues. So the payment at the moment is a quite low for the doctor, but the people argue that, oh, it's a low for every profession, so we need to increase for police, teacher, and army, and the nurses, and everyone. But um, unless and until country develop, it won't happen. But I think the coming back to your question is that there's a WHO guideline, there's a protocol that the developed country should not take the health worker from developing country, but there is another loophole where they can do it. So the best way is the way we train. I don't think that decreasing the quality of training is the option. There's some country in African country, they reduce the duration 4 years nursing program to the 2.5 years, so that it's not recognized in developed countries, so that they can't go there. And then that's how they manage to keep some of those nurses in the country. So they said some country has adopted those approaches, and they are quite strict on some countries has quite a strict rule on the people who study on the scholarship, and they have to reimburse all the money if they decided to leave the country. There are different model in different country. So we need to. I think it's a quite worrying situation now. And then the majority of the people who left, majority of the doctor who left the country are the doctors who study under the scholarship. There's all the medical school in Nepal, they should provide 10 to 20% free places. So there's a quite large number of doctors and nurses now get the scholarship to study the medicine. And the people who get the scholarship are the clever one, because they got the high score on the exam. And those clever are the one who easily can pass the PLAB exam or USMLE, or can move to the other country. That's a bit of dilemma on those one. So I think we need to revisit the basic things. We need to revisit how we train out the health worker in the country.
Right. Okay. I think I would like to just finish now, you to say, reply these a couple of things here in within a minute, because I don't want to take much longer time. Pushparaj Panta, I think bringing this idea about because there are now universities and academia doing research locally and provincial level in strengthening health system in Nepal. When there were not many universities, medical higher education institutions, when the current health system was formulated. Now there are many universities in each of the 7 provinces. I think that may not require answer, but just highlight the change context. And Per Halmerson was interested about how our mental health challenges are addressed within the organizational framework you describe. I think if there is anything left, we won't take. I mean, the question about the role of NGOs being great and they are facing challenge of sustainability because due to the problems in international funding also raised by Sapana Subedi. But maybe if you'd like to briefly toss on these couple of points, then we will wrap up. Thank you.
Yeah, I think I missed the mental health is one of the area that I think the Edwin is in the team as well. We did some research and work on the mental health is something is really ignored in many ways. There's a very few psychiatrists in the country. The mental health issues is not cooperated in the primary healthcare in many ways. It should be, and I think the when we talk about the framework or the WHO health system building block, if we strengthen the few aspects, service delivery side and other area, that I think is an important aspect. And then the mental health is part of the non-communicable disease, and it's one of the burning problem as well. Yeah, there's no doubt, no question about this major public health issues, major issues. And again, our health education training is still in a time when we got the non-communicable disease was a major problem. So that's why I mean our shift in medical education is also required. That's why I keep saying that we need to shift that paradigm in terms of priority and how we train our health worker, and mainly in the local level, lower level health worker need to train on mental health issues as well.
Okay, with this, I would like to thank all our esteemed participants for patiently listening to this talk and also engaging. There has been a huge interest and a lot of questions and comments. So big thanks goes to our friends for joining from different parts of the world. And we look forward to welcoming you to our next talk. Next actually would be a very interesting panel discussion, in a very significant topic of interest, which is about the question of citizenship and diasporic Nepalese. Naresh Kapangiji has been coordinating this. So please don't miss that program. And the first Saturday of the next month will be 5th April, same time, 10 o'clock. And also, I'd like to appeal all our friends, for collaboration with ideas. If you want to, co-run this event with us, please let us know. Also, ideas. Who would you like to bring, and what subject would of our interest. We always welcome all those ideas. And I would like to thank Professor Padam Simkhada, despite being so busy this month, for accepting our invitation to give a talk and delivering this fantastic presentation today, and engaging in this dialogue. I mean, health is a huge issue, and we can only get engaged on this one. Our aim is eventually to come up with some kind of publications in the future. So Padam Simkhada, when you have time, we expect of critical paper. Of course, many subjects cannot be covered, but concentrating on the how fit is Nepal's health system, so that we can contribute to Nepal's policy making. So that with that request, finally, my thank you goes to all my friends here today, and we look forward to meeting you next month. Thank you. The meeting would be over, and I'm now going to stop recording, and we'd like to